The next session is top ways that climate will change your clinical practice. Dr. Emily Cavallo-Hynes will be our expert presenter for this session. She is a specialist in emergency medicine and public health. She is trained at academic medical centers in the United States and cross-trained in austere emergency care environments through the International Committee of the Red Cross, Harvard University, and the World Health Organization. Her professional interest is in developing emergency care capacity via innovative approaches to health system strengthening and education of healthcare personnel to provide best practice service delivery. Among her field experiences, she has served as Director of Emergency Services for International Medical Corps immediately after the 2010 Haiti earthquake, Senior Technical Advisor to Catholic Relief Services during the Haiti cholera epidemic, and is senior faculty at JFK Medical Center in Monrovia, Liberia from 2009 to 2013. She is a consultant in the United States State Department for their senior crisis management and hospital-based management of mass casualty incident courses held throughout the world, and serves as a visiting consultant to the World Health Organization's program for emergency, trauma, and acute care. Dr. Cavallo-Hynes attended Bryn Mawr College, where she earned a Bachelor of Arts in Chemistry, followed by medical school at Johns Hopkins School of Medicine, while simultaneously earning her Master of Public Health from Johns Hopkins Bloomberg School of Public Health. She completed an emergency medicine residency at Johns Hopkins Hospital, Johns Hopkins University. She holds faculty appointments in the United States at the University of Colorado School of Medicine, in South Africa at the University of Stellenbosch, and in the United Arab Emirates at the University of the United Arab Emirates Faculty of Medicine. She has served as a Johnson & Johnson Fellow in Liberia, senior faculty at the University of Maryland Global Health Interprofessional Consortium, and currently sits on the scientific committee of the African Federation of Emergency Medicine and the Consortium of Universities for Global Health. Her awards include the University of Cape Town Visiting Lecturer Scholarship, University of Maryland Teaching Award, the Johns Hopkins International Scholarship, the Johns Hopkins Service Excellence Award, and the Hubler Award for Excellence in Public Health and Medicine. She has also received the Johns Hopkins Alumni Association Global Achievement Award and the Colorado School of Public Health Center for Global Health Excellence in Global Health Award. Just to share a few more accolades to explain her expertise. These are just a few recent publications that I pulled. Her and Dr. Bills published on emergency care systems being the missing link for effective treatment of COVID in Africa. She has worked on evaluating emergency care capacity in Africa, and then she has worked to develop emergency care systems as a human rights-based approach. Dr. Cavallo-Hynes, thank you for being here today.
Hello, everyone. This is Dr. Emily Cavallo-Hynes. It's awesome to be with you guys today, and we are so excited to bring this topic to you. I have been charged with presenting to our audience of mainly clinicians 5 ways that climate change will affect your clinical practice. And here is why I want to give this talk. When we're thinking about the continent of Africa, no region has done less to contribute to the climate crisis, but no region will pay a higher price for failure to tackle it. All countries stand to lose, but Africa will lose the most. This was first said by Kofi Annan in 2015. And here's what we know. Africa can easily be said to contribute the least of any continent to global warming. Each year, Africa produces an average of just over 1 metric ton of greenhouse gas carbon dioxide per person. If you think about the comparison with my country, which does a terrible job with this, the United States alone generates 5.7 billion metric tons of carbon dioxide per year. That's 23% of the world's total, making it the leading producer in the world. Africa as an entire continent only contributes about 4%. So it's a really cruel irony that the people living on the continent that has contributed the least to global warming are in line to be the hardest hit by the resulting climate change. And this is really why we're pushing forward this pre-conference to you all. And I don't say that to be fatalistic, but just rather to have a clear-eyed look at what's coming at us in the next 30 years. So as clinicians, I wanted to focus on things that matter most to us, and that is, what do we do with our daily clinical practice? So here are my objectives for this talk. I want to describe the major forces that are changing clinical presentations in the emergency units. I want to list 5 fundamental ways that climate change can profoundly affect the delivery of emergency care, and consider the implications for how climate change can stress poorly prepared emergency health systems. You all have likely seen this slide before. We like to use it because it really encapsulates the complexity of the impact of climate change on human health. So when we look at rising sea levels, more extreme weather, rising temperatures, and increasing CO2 levels, this has various effects on exposures, which then go on to change market health outcomes for humans in all these different domains. This is an excellent summary slide, but I'll tell you that I think a lot of clinicians have a hard time getting their arms and minds around kind of the complexity of climate change and what that actually means for their clinical practice. I will also say, though, that I have infinite faith in emergency medicine. We are a specialty that really thrives in complexity and the messiness of life, so let's dig into this a little bit more. When we think about the climate impacts on the health system, there are a number of things that we know are going to happen. There are going to be changes in the volume and patterns of health service demand from increased morbidity and mortality. We know there's likely going to be reduced capacity to meet the primary public health needs due to interruptions of vital components of the health system. So whether that's infrastructure, equipment damage, or reduced staff, which by the way we're seeing now, of course, with COVID-19. And then interruptions of health determining service, such as access to clean water, sanitation, food, energy, communication, all the upstream effects that we talk about in public health and how that affects emergency conditions. Really, all of this kind of complexity and its possible effects can be summarized in really this one statement, which is climate change is an issue of disaster and vulnerability. And there's no field of medicine that does disaster and vulnerability better than emergency medicine. So without further ado, let's talk about the top 5 ways that climate will affect your clinical practice. I'm going to just buzz through a number of these domains in order to emphasize for you what the literature has showed us to date. I will say, and Dr. Bills will likely back me up, that the literature that's been published thus far has remarkably few studies that have been included from low and middle income countries and Afro regions specifically. So here's what we're going to talk about. We're going to talk about trauma, communicable disease, non-communicable disease, mental health, and then the ways that climate is actually going to cause increased disaster frequency, requiring emergency units to surge. So let's talk first about trauma. Let's start with trauma, the bread and butter of emergency medicine. I think lots of folks can see the correlation between traumatic presentations and climate change. So when we have a disaster or an extreme weather event, we do see spikes in ED utilization for trauma and injury. Or when we see heavy precipitation, we know that there's an increased risk of motor vehicle crashes and resultant traumatic injury. However, there are some more nuanced associations that is nicely summarized in the Sorensen article that's referenced below. And some of those things have to do with heat. So we know heat is associated with increased frequency of traumatic injuries, presentations to trauma centers, or increased risk of assault and homicide. Interestingly, there's also risk of increased workplace-related injuries such as slip and falls or lacerations or burns or amputations. And this is pretty fascinating. You know, there's association with heat. I don't know if we know causality per se. There's lots of folks who kind of talk about what that might mean and what those causal agents might be. But there is definitively an association with trauma and increased temperature and warming. With each of these domains, I'm also going to include a quick case study to just have a couple more minutes to talk about diving a little bit deeper in some examples that we see. So for trauma, I chose the case study of the first named climate war in Darfur. And what we've seen with Darfur has been a number of different things that has led to increased trauma an increased violence among people groups. And that is, first of all, deteriorating livelihoods. Those deteriorating livelihoods have been brought about by drought, by climate change, and then this conflict that's got set up between farmers and pastoralists who depend directly on some of the agro ecosystems for their livelihoods. And so when drought or floods or land overuse and degradation leads to decreasing production and economic loss, this can set up a situation where there could be more interpersonal violence. Where there are deteriorating livelihoods, there can be increased migration. So resource scarcity in one area may lead to migration to more favorable areas within the same region. And this was certainly the case in Darfur, where there was other areas with biomass growth that occurred from 1982 to 2002. And then there was increased outbreaks of violence, which also drove increased migration. We know that when people move, their health is actually worse. We have seen that kind of in all the refugee research that's ever been done. And closely related to this point number 2 is the third thing that's really contributed to some of the Darfur conflict, which was changing mobility patterns among pastoralists. Their traditional grazing areas became insufficient due to climate change, and this caused altered migration routes that put them into increasing contact with different people groups that could also seem to lead to more interpersonal violence. The climate itself also led to tactical considerations among armed groups. So we know that, say, livestock theft increases significantly during the rainy season or periods where the vegetation cover increases, probably because it's easy to find protection and the animals are in better condition for being herded over long distance. So climate in and of itself can contribute to how people think about when they're actually going to inflict either theft or interpersonal violence upon another group. Finally, in Darfur, the thing we saw was that the elite actually exploited these local grievances. So as all these factors came together to increase some of the interpersonal violence that was being seen, those who were in power really used that conflict to mobilize support from other ethnic groups against others and to enhance tensions that might solidify their control over the region. So again, this all kind of lends itself to complexity, but this is how this complexity came together in Darfur, particularly to really perpetuate the conflict there for a long period of time. If you all are interested in this, there's actually a great podcast called Climate Wars. It's put out by BBC, and I'll have it linked in some of the resources that we're going to give you so that you can learn more about this. Let's move on to communicable disease. I think a lot of folks understand that, with climate change, we can see different effects on communicable disease, but what is this going to really mean to you all in your emergency units and with the patients in front of you? Well, first of all, we know that heavy precipitation events are associated with waterborne outbreaks of disease. And there are at least 8 climate-sensitive pathogens that account for 97% of all this waterborne illness. In addition to that, the elevated sea surface temperature for those coastal nations and regions could see increased incidence of ciguatera fish poisoning or increased rates of illness for all types of Vibrio infections. They're very much temperature dependent for the number of bacterial counts in the water, and then increasing rates of paralytic shellfish poisoning. So not only are we seeing the effects of waterborne disease, but we're also seeing vector-borne and zoonotic disease. We happen to be living right now in a place and time where we are experiencing a global pandemic with remarkable numbers of excess deaths due to a disease that was primarily zoonotic in origin and then spread to the human species. And so a lot of commentary right now is in the literature about whether we're living now in the age of pandemics. And what that means is, are we going to be exposed to new and deadly viruses due to population growth, due to climate change, and the increased contact between human and animals? In addition, we're also seeing that our current pandemic actually is influenced by some of the human effects on climate change. So, for example, air pollution has just been shown, this was just published actually last week, to be an important factor in increasing the risk of mortality from COVID-19. And this should really provide ambitious policies to reduce air pollution in addition to the measures that we're putting forward to control the transmission of COVID-19. But COVID-19 is only one thing, right? We have many currently circulating climate-sensitive diseases, and there are viruses such as Zika, dengue, chikungunya, which we talk about a lot. Rift Valley fever is another one, as well as West Nile, and then parasites that are also climate-sensitive. The one that's probably best studied is malaria. So let's take a little bit closer look at that and what that's going to mean to your clinical practice. Malaria is super interesting because at first pass, we would think, look, there's going to be more areas of the world that are warming, and there's going to be a possible extended distribution of where the Anopheles mosquito could live and therefore where malaria could be transmitted. I will note for you all that those could include many places in the United States. And some of the early WHO publications that talked about this, about climate change and infectious disease, thought that the temperature increase that we're anticipating by 2050 of 2 degrees to 3 degrees could increase the number of people who are at risk of malaria by around 3 to 5%. So that seems like a small number of people at risk, but that really what that means is we could see several 100 million more cases of malaria. But what those predictions really didn't take into account was these issues around climate suitability, the population at risk, and some of the other large themes that are ongoing in our world right now, including urbanization. So let's talk a little bit more about that. So this study that was published in Lancet Planetary Health just a few months ago took a much closer look at how things like population density, climate sensitivity, and urbanization could have on what we anticipate about how many cases of malaria will we see by 2050 and 2080. So just to explain this figure a little bit more, across the top, you have malaria risk that's defined here on the continent by this big red circle, and how that actually shifts based on how we think the climate is going to change in Africa. And then on the bottom is the arbovirus risk. So those are the viruses that can be carried by mosquitoes, such as dengue, chikungunya, Zika, etc. One other point to note, the scale at the bottom just describes the number of months of the year predicted to have highly suitable temperatures for disease transmission. So that's what we're looking at on this visual. And what they found in this was that temperature actually has a non-linear effect on vector-borne disease transmissions. The mosquito and the pathogen species differ in this response, resulting in differences in their kind of thermal optimization and the limits. And so what this means is that you can get maximal malaria transmission around 25 degrees Celsius, whereas arbovirus transmissions, and say Aedes aegypti, the mosquito that carries dengue, Zika, chikungunya, peaks at about 29 degrees Celsius. So things are not as simple as we think. It's not just that the climate's going to warm and there's going to be more malaria. Rather, what we think in these predictive models is that climate change and urbanization could drive a shift in most of sub-Saharan Africa from climates most suited for malaria transmission to climates that are more suitable for transmission of dengue and other arboviruses because of that shift in temperature. This obviously has major consequences for public health and disease control strategies, and also has market implications for you, the clinician, about who's going to show up and what's actually causing their fever. All right, so moving on to non-communicable diseases and the effects of climate on these. Here is what we know about non-communicable diseases, or NCDs, and particularly around cardiovascular disease. We know heat events and increased warming is associated with increased emergency department visits for cardiovascular and cerebral vascular disease. We know that heat events are associated with increased risk for cardiovascular deaths, and that poor air quality can increase emergency department usage for cardiovascular disease complaints and dysrhythmias, which is pretty astonishing. In addition to that, wildfires are associated with increased out-of-hospital cardiac arrest and ED presentations for ischemic heart disease. So there's a very clear correlation with some of the climate-related health effects and cardiovascular disease. If we're thinking about wildfires, this was just one picture of what happened in the United States this summer. It was astonishing, the millions of acres that were burned because of drought and because of an increased warming climate. But wildfires can also affect respiratory disease. So let's talk a little bit more about what the data shows us with regard to who's going to show up in your ED. Ozone and particulate matter pollution are associated with increased risk of acute respiratory exacerbations and more visits for asthma among kids. That wildfire smoke exposure can increase COPD presentations, asthma, and just generalized dyspnea. And some of these heat events that we see, just in and of by themselves, can cause respiratory disease exacerbations, aside from kind of what the air pollution and particulate matter is. So just heat itself, again, can cause increased respiratory disease. And then elevated pollen levels, of course, that come with a changing climate can be associated with environmental allergies or increased ED visits for asthma. So that's what the data shows us. So let's dive in a little bit closer with this case study on air pollution. We just had a report that was released called the State of Global Air 2020. And what they did is they looked at kind of what the particulate matter was in the various locations in the world, and they found a pretty astonishing thing, which was that air pollution is the fourth leading risk factor for premature death worldwide. If you think about that, that is astonishing. And it's because air pollution can contribute to so many causes, and that includes COPD, which I mentioned before, diabetes, ischemic heart disease, lung cancer, stroke, lower respiratory infections, and then astonishingly, this report also reported that 20% of neonatal deaths are attributed to air pollution. And so when you actually do the numbers on this, in 2019, they summarized that the air pollution contributed to nearly 500,000 deaths among infants in their first month of life. So this made a pretty big splash in the media because nobody likes to see babies killed, ever. And if we're dealing with air pollution that we can actually change, that could really decrease the number of deaths of neonates, we should absolutely do that and advocate for that as clinicians. I wanted us to just touch briefly on this case study of malnutrition as well, because we do consider it a non-communicable disease and it is profoundly influenced by climate change. And so if we look at this causal pathway, which gets into the weeds a good bit, but it just helps to kind of help us think about how does climate change and human activity actually end up causing malnutrition, especially pediatric malnutrition. So we have our greenhouse gas emissions, right? These cause climate and atmospheric shifts that then go on to cause proximate biological consequences. And so what do we mean by that? That means more exposure to enteric pathogens. This means changes in our food sources. So both the ones that we grow and the ones that we raise, like animals. It also means, though, that there's a lower human labor capacity as well, especially with extreme heat events. And this goes on to impact human socioeconomic systems as well, where we have a higher frequency of conflict that we described before, kind of in the trauma section, lower crop yields, altered livestock productivity, altered fish catch, of course, that then go on to affect altered global nutrient supply, as well as increased diarrheal disease and enteric infections that we've already spoken about. And so all of that combines to alter nutritional status for the human species. So really we can look at all kinds of causal pathways, but really what we care about always as clinicians as the patient in front of us. And what does this mean for them? I know you all work in a number of different places where you might see malnutrition more frequently. We think there is going to be more of this as the planet warms, as we see the effects of climate change. And so what does this mean? This means that if we see malnutrition, it doesn't just have short-term effects. We know what some of those are. So especially for kids, there's impaired brain development, lower IQ, and a weakened immune system. But we also know through the research that the effects of stunting and malnutrition have long-term effects, such as lost productivity and healthcare costs, of course, smaller stature, but also this greater risk of, by the way, non-communicable disease, which is, of course, the domain that we're talking about right now. Those can all combine to also affect premature death. So malnutrition in and of itself is a force multiplier that's really caused by what we're seeing in a warming climate. All right, let's shift to number 4 now, mental health, and what this is actually going to mean to you in the emergency units. So, how on earth does climate actually affect mental health? Here's what we know from the data. Extreme weather events are associated with increased alcohol and substance abuse, post traumatic stress disorder, depression, and anxiety, and associated with increased rates of rape and domestic violence. So, going back to that trauma linkage. I'm sure you all are also seeing in your emergency units that COVID-19 in and of itself and the lockdown and the pandemic is actually causing problems with these things as well. We know with heat events and increased temperatures, it does cause increased emergency department usage for mental health complaints writ large, including increased risk of interpersonal violence and assault. I would also say there's interactions as well with this increased temperature on our patients who are currently taking psychotropic medications that can put them more at risk for hyperthermia and things like that. So we also need to be aware of kind of what the particular vulnerabilities are among our mental health patients. But thinking more generally, as we think about our patients and kind of what causes these changes in mental health, we're back into this kind of figure that shows us how all these things are interrelated. So, of course, our mental health is not separate from our physical health. So, we know what some of those things are in the context of how climate affects both injuries, vector borne disease, as we discussed, some of the non communicables. That ties into how you feel, right? That your depression and stress and anxiety, your strain on social relationships, the use of substances, and also some of the loss of personal identity. There can be a sense of helplessness and a fatalism, especially when people are dealing with things that they cannot control, such as the COVID-19 pandemic or climate change. And all of that kind of comes together and impacts specific vulnerabilities and our own sense of community health. So, the fact that climate change also affects what happens within our communities, this disrupted sense of belonging, increased migration, the loss of community cohesion, all of that actually plays back into how we feel and what our mental health is. And so this is why actually there's been a lot of publications around how climate change is actually going to affect mental health. And the first place people turn when they're in crisis, of course, is to you, the provider, in our emergency units. I wanted to use this case study of climate migration to talk a little bit more about how these global forces can really influence mental health particularly. We touched on migration before in the climate war example, but I wanted to talk about migration and this term that some people throw out called climate refugees. These folks are actually not considered refugees by international law, but they are forced to leave their home countries due to climate change. And there are several Pacific Island countries, including Fiji, the Solomon Islands, Papua New Guinea, that are planning for and implementing planned relocation because of sea level rise. But the health risks and the opportunities of relocation have really received somewhat limited consideration. And so I gave you guys a reference down here just to kind of consider what some of the folks who are going through climate migration who may show up in your emergency units are dealing with. And so some of those are direct effects, right? So what happens with heat wave, that has a pretty direct effect with regard to mental health that we've already discussed. But there are other things such as indirect short-term impacts that can really affect mental health, such as floods and tornadoes and hurricanes. And then these more indirect long-term effects of mental health, such as, how does the mind grip and cope with changes in the territory, such as prolonged droughts or increased sea levels or deforestation or forced migration that then goes on, we know, to disrupt communal ties and to cause significant health stressors and often mental health stressors as well. I would say it's also important to realize that the consequences of climate change, such as kind of economic or social difficulty, contribute not only to the increase in the incidence of mental illness through these different effects, but also in the subsequent generations. And this, I think, has been a stunning finding in the last decade of research about how changes in the mental health of the population now and our patients now can really affect their children and their children's children. All right, moving on to our last domain that I really want to make sure we discussed about how climate change will affect your clinical practice is we expect to see increased disaster frequency requiring emergency unit surge. So if you actually look at the numbers, and this is through 2019 here, Here are the number of reported disasters along the y-axis, and the colors indicate the different types of disasters that have occurred. When we look at this, what we see is the number of natural disasters has risen in the last 30 years pretty remarkably. There was a Lancet countdown on health and climate change that concluded that there's been a 46% increase in extreme weather disasters since 2000. And if you don't believe me, just consider what we have been through in 2020. So we've had the flooding in Sudan as just one example, COVID-19 that has hit the continent and the rest of the world, wildfires throughout Africa, and even the locust infestation that was occurring in East Africa was absolutely associated with with a changing climate. Some of the increases in temperature and rainfall over desert areas and strong winds with the tropical cyclones provided a new environment for the locust breeding and migration. And so even things that we think look like kind of an act of God are absolutely associated with what we're seeing with climate change. One of the interesting things is The thing I think is interesting is that many people have forgotten that there's an intimate relationship of the emergency care system and disaster response. In fact, if you look at most disaster response documents that are published internationally, they infrequently, if ever, make mention of actually the National Emergency Care System and its relationship in being able to provide mass casualty management. So obviously there are things that the emergency care system does that are absolutely essential, including surge, to be able to manage mass casualties and contribute to the disaster and outbreak response. That leads us to this conclusion, is that really emergency units in low and middle income countries are ground zero for climate change and human health. You as clinicians are the ones who are going to be taking care of these patients who are going to come to your emergency units in increased frequency. And we are also going to be required in the midst of that to surge for increasing disaster frequency that we know we are already seeing. And I would also say this, while we have made some great strides in the last 10 to 15 years regarding emergency care systems and their ability to be able to provide some of these services, we are still not ready. And we are undeveloped, really in many locations, for the threat to human life that climate change represents. And I would submit that building emergency care systems in low and middle income countries should be a central part of the climate change mitigation strategy. And that is exactly why I, as a clinician, feel so strongly about this issue. So just to review, we've gone through the top 5 ways that we think that climate change is really going to affect your clinical practice, both in trauma, non-communicable disease, communicable disease, mental health, and increased disaster frequency. And we are here to tell you today that despite the fact that things look fairly grim, there is a lot for us to do and a lot for us to advocate for, and a lot of ways that you can change what's happening in your own local communities. So stay tuned for that, because we're going to talk about that in our next couple sessions. Thank you guys for listening. Be well.
We would also like to introduce you to State of the Climate in Africa, a report by the World Meteorological Organization. It has key indicators and climate science in it that can be helpful in many of your educational and research initiatives. It also has key policy opportunities that you can become involved with. There are 2 key resources for the end of session 1. The first is the 2019 report of the Lancet Countdown on Health and Climate Change. The second is the Intergovernmental Panel on Climate Change Synthesis Report, Climate Change 2014. Both of those have extensive climate science and health information. We'll now move on to discussion 1.